lymphatics and immune is going to be the next test. This is a very, very short lecture, okay? And again, I'll be curious after Tuesday what you think about the order of the class. So once you get all the information on Tuesday for the immune system, be very curious to see what you think about using hematology and immune together, because that's how other people tend to teach it. And again, I taught it that way, and I can't stand it. I think that it's just too much information for you guys, especially for a summer term where we're trying to, shove a bunch of information down at you. So again, the plan is going to be to finish everything by Tuesday, so that Wednesday will be a day that I'll be here. You can come in and study. You can come in and ask questions. You don't have to come at all if you don't want to. And then Thursday will be your final. Okay? Same class time, same arena, and I will try and then have your grades done by Friday, so you'll have the grade on the exam and the grade in the class. I will repeat this on Thursday when I give you your final. You're going to get the best grade that you're going to get. I can't tell you not to email me, so unless there's a discrepancy in the scores, usually you email me going, how come how far away am I from an A? You're going to get the best score you can. So, again, I can't tell you not to email me, but it's never really benefited. All it really kind of piss you off, because it's usually done by people who didn't show up to class or those types of things, and it's like, now you suddenly want all of this, positiveness sent your way when you really didn't earn it. So, but again, if you really feel the need, please email me and ask. Lymphatics, again, very straightforward. This is the sewer system of the body. Okay? So remember what we talked about in the vascular chapter, the very last day, where we talked about fluid that was leaking out of the blood vessel, which, by the way, is usually a question I put on there, so I did not put that question on your exam, which is describe the four forces and which directions they have a tendency to push, just because a lot of students hate that particular section. But when you think about it, fluid, so again, if this is a capillary, this is the arterial end, that's the venous end. Remember, these are exchange vessels. So stuff has to be able to move out of the capillary in here to the tissues. Okay? Again, if you want to kind of think about where you guys are at, if each of your tables is part of the capillary system and you are cells, then there has to be stuff that leaves this tube here that gets to you. So you get your oxygen, you get your nutrients, you get your peanuts, pick up the trash. Now, when I went over that, we lost fluid at the arterial end of the capillary system, but we regained most of the fluid on the venous end. Because if we didn't regain that fluid, every time blood went round and round in our tissues, the fluid would leak out in the vascular space. We'd look like the Pillsbury Doughboy, and we'd have no circulating blood volume. Why? Because there's no blood in the vascular space. It all leaked out. That's why we reclaim it. There's about 3 liters that we don't reclaim. Okay? But again, I have to get that back at the end of the day because we only have 6 liters circulating around. So we do that with the lymphatics. So here we see, and she flipped the thing. Usually our arterial end is on this side, we move that way. But so here's the arterial end, and it's moving through the capillary bed. All of these are the tissue cells. They're being delivered nutrients, oxygen, and then blood is moving over to the venous side. And apparently the fly wants to participate in the lecture. Now, as fluid leaks out here, most of it's going to come back through here. It's going to get reabsorbed in the venous side. The small amount that doesn't will get reabsorbed into the capillaries of the lymphatic system. Okay? Where then we'll start to move just like the venous system. And these parallel the venous system very closely. In deep ones, they tend to parallel the arterial system because that's one of the things that's going to help the lymph move. Now, as this moves from capillary, we go to what are referred to as the collecting vessels or the lymphatic vessels. And then from there, we're going to go to lymphatic trunks and then ducts. So that's the order that you're moving through as you get to larger and larger structures. Okay? Now, throughout there we have these things that most of you have heard called lymph nodes. And the lymph nodes, that's really the sewage, the treating center. This is where all of this fluid is going to get cleaned over and over and over again. It doesn't just go through one. It's going to go through multiple ones as it moves through this process. Okay? Now, when we look at the structure here, okay, so it used to be thought that these things were open, like a giant straw. So if this was a lymphatic, that the end would be there, and that's how stuff moves up, almost as if somebody's like and sucking everything up into it. Okay? The end is actually blunt. It's off. There's no entry into it. Okay? This is why the structure is slightly different than the vessels that we went over. Remember, the blood vessels that we went over had the same three layers: the tunica intima, the tunica media, the tunica externa, the tunica adventitia, but it was essentially endothelial cells, a little bit of muscle, and then connective tissue on the outside. Okay? These are shaped like shingles. Okay? So this fluid out here, and this part is a little bit more specific. We're going to talk about this in the digestive system, where we change the names of things as it moves to a different structure. So when the fluid exists out here, it's called interstitial fluid. Okay, and again, just to make sure everybody's on the same page, if you think about this desk in front of you as being part of a capillary system, that's the blood vessel, and you yourself is a cell, everything around you, up, down, in front, behind, that's not inside the blood vessel. If it's fluid, it's called interstitial fluid. Okay? So this fluid that exists here, when the pressure gets large enough, it pushes down. So again, this is shingling. So when it pushes down, it's like a trap door, a flap. And fluid goes into the capillary. And then when the pressure gets greater inside the capillary, valve shuts. That's how the fluid out here gets back into the capillary system. Now when I say capillary, I'm talking about the lymphatics, because they are called capillaries. These are just lymphatic capillaries, different from the vascular capillary. Now, this is where I was referring to things being specific. That is no longer now called interstitial fluid. It's called lymph. So when we refer to the term lymph, we're talking about fluid that now exists inside a lymphatic vessel, whether that be the lymphatic capillary, the lymphatic collecting vessels, whether it be the trunks, whether it be the ducts. Now, you remember the analogy I talked about where when you do a lumbar puncture, the main reason that we do it below about L2, L3 is because you had those spinal nerves that exited out, and you had the spinal cord that terminated about L1, L2. And the reason that we like to do the lumbar puncture there is because if I have all these nerves and I stuck a needle into it, it's like pushing your hand underwater where there's foliage. As you push your hand, the water movement essentially moves those nerves out of the way. Well, if the same type of thing could happen here, then there would never be enough pressure on the outside to trigger that flap. It would just simply push the vessel away. Okay? So we have these filaments that are right there that essentially attach to tissue. Sometimes it's the capillary bed itself, so that it can't move around. So that when the pressure gets large enough from the increase in interstitial fluid, it has the ability to push and increase entry into that process. Any questions on this? Okay. Now, this is a good number to kind of remember. Okay. Most textbooks, instead of using a number, they'll tell you that it's about 15% of blood, or the fluid that leaks out, that is going to get reclaimed at the end of the day. This is probably just an easier value. And again, it's happening throughout the day. It's not just, again, when you go to bed at night, you suddenly the lymphatics increase and we pull the fluid back up. some proteins do leak out of the capillary system, of the vascular capillary system. And remember, why don't I want proteins in the vascular capillary system leaking out? If I have proteins that are where you guys are, in the interstitium, so surrounding you top, bottom, but they're not leaked out of the capillary, the desk in front of you, why is that detrimental?
They attract water.
They attract water. So I don't want them out there. So the few that do leak out, they're also going to come back in. And they're going to enter into the lymph so that they can be returned back to the blood. That's the goal of this. I'm going to reclaim the fluid. I'm going to call it lymph. I'm going to clean it, clean it, clean it, clean it, clean it, and then I'm going to turn it back into, or send it back to the blood. Okay? The structure, after we get out of capillaries, is essentially the same. Same three layers that we have in the vascular system. The tunica intima, the tunica media, the tunica adventitia. And again, the order is lymphatic capillaries, lymphatic collecting vessels, trunks, and then ducts. Now, the trunks are essentially named for two reasons. One, their location, and two, the area that they tend to drain. In other words, that things move back into them. Lumbar is going to be down here, so anything that's coming from your lower legs is going to go through your lumbar trunk. Bronchomediastinum. Anything that's in your chest is going to drain into that trunk. Subclavian. Usually things from our arms. It's going to drain into the subclavian trunk. Jugular. Stuff from my head. And the last one, the abdominal viscera, so the abdominal cavity, is going to drain into the intestinal. Now there is a structure that exists, and it's called the cisterna chyli, and it's right here. And this is where you have the beginning of what's called the thoracic duct. Not everybody has one, but we have a lot of our intestinal and our lumbars that drain in here. So it's just this enlarged area. So right after trunks, we go to ducts. Now, unfortunately, for students, people decided not to name these in an appropriate, what I would consider an appropriate way. So here, we're going to return the lymph back to blood exactly where we have the internal jugular and the subclavian. So if you want to say on an exam it returns it back to the brachiocephalic vein, that's fine. Because that's exactly what occurs at the junction of the internal jugular and the subclavian. So right here, this is referred to as the right lymphatic duct. Now, over on the other side, in the exact same place, we have the left internal jugular, the left subclavian. So there's where we have our left brachiocephalic, and there's where we have it. And guess what that one's called? It's not called the left lymphatic duct. It's called the thoracic duct. I want to make sure that you're aware of that. Okay? Don't know why they changed it. Primarily because the theory is because of what's drained, and I'm going to show you a picture of it in just a second. So again, in your notes, make a distinction. Thoracic duct on the left, right lymphatic duct on the right. Same structure, just a different name. And not the same structure, but the same identical structure. Now, why is there a slight difference? Well, remember I told you that some people have this thing called the cisterna chyli down here? And directly after the cisterna chyli is where the thoracic duct begins. So the thoracic duct actually is down here. It just empties up to that point. So this is the deeper thing. Now why is that important? Well, when we look at what is draining into each side, so here, kind of a little hard to see, but there's a delineation right here. So what drains into the right lymphatic duct is essentially the right side of the head, the right arm, and the right chest. Everything else drains into the thoracic duct. That's one of the reasons why it starts right after the sternocleidomastoid, which is right there. Any questions on that? Okay. Now, as we start moving up and the vessels start getting larger, it has the same overall structure of our arteries and our veins. And remember that the arteries and the veins do not derive their nutrients and their oxygen from what's inside of it. They have a special blood vessel that goes to it called the vasa vasorum. Same with the lymphatics. So the lymphatics have blood vessels that are going to come into the outer layers to nourish them. Now, this is one of the reasons why it's, I think, important to always come to class so that you can hear the lecture. And again, to reiterate the point that this isn't for you, this is for me. Vasovasorum does not equal lymphangitis. This is just my way so that I remember what I'm supposed to talk about. If I have a blockage in a lymphatic vessel, then the blood that comes to it, the blood vessel that comes to it, can get obstructed as well. And the blood vessels will then kind of back up and become very red, very painful. And they travel kind of along the length of the lymphatic vessel. And that's referred to as lymphangitis. So again, vasovasorum is not lymphangitis. Vasovasorum are the blood vessels that go and nourish the larger vessels, whether it be lymphatic vessels, whether it be arteries, whether it be veins. Lymphangitis is just simply the red streaking that appears when the lymphatics are blocked. Because this is starting to back up. The vasovasorum is starting to back up.
So the lymphs do have vasovasorum, or it's called that in the lymph system?
Yeah.
Okay.
Just like in the arteries in the vein. Now, the flow, because this is very similar to veins in that they have to have movement going up against gravity, okay, because we're moving in the same direction. Fluid movement, lymph movement in lymphatics moves in the exact same direction that blood moves in veins. It's going backwards. It's going back up because it's going to drop back into the system. They do have valves, just like the veins do. So that's going to be one thing that's going to facilitate this process of moving things back up towards the heart. Okay? They also have that muscle pump. So as I walk around in my veins, the same thing that's going to happen in my veins is going to happen in my lymphatics, where the muscles, as I contract my muscles to walk, will be squeezing the lymphatics. So that's going to, again, help move things in an upward direction. We have our respiratory pump. Now remember, exactly the same as the veins. When I take a breath in, creates a negative pressure in my chest. That negative pressure then gets transmitted to the great vessels. So the veins will experience a decrease in blood pressure. And remember, things move from an area from high to low. So if I have a higher pressure at one end, and I create a negative pressure, and as we already talked about, and we'll talk about again in the respiratory system, we don't really create a negative, it's just a lower pressure, but we call it a negative pressure, okay? Down here, then it's going to facilitate fluid moving back up, all right? Or higher pressure, lower pressure, you move it in this direction. Now, two other things. One of them's not on there. I'll talk about it in just a second. If you go to this picture, you've got this physics occurring here. So blood is coming back to the heart via those two structures. As the velocity of blood goes past this opening right there, it creates a negative pressure. Again, since it's a negative pressure, it's called entraining. It's pulling the lymph in. Okay? So that's the fourth thing that that facilitates lymph moving back towards the heart. The fifth one, I told you that these structures tend to be very close to our arteries when they're deep. In other words, deeper in the body, not superficial. So right along this area, we're going to have larger blood vessels, primarily the aorta. As the pulse of the aorta, since it's so close, every time you have a beat, it pushes on the lymphatics, and that's just kind of like the muscles. It squeezes it, so they're going to keep moving in an upward direction. So there's 5 things that facilitate lymphatics moving through lymph, moving through lymphatics. It's still very slow. Anybody want to hazard a guess as the reason why it's so slow?
Filtering things along the way.
Cleaning process. It gives time for the lymph to be cleaned over and over and over and over again. Do you have a question?
Can you repeat what you said, the pulse of the aorta, the impact that has?
It just pushes on the lymphatic, so it works the same way that the muscular pump works. Now, at any particular point, fluid that does slowly leak out into the interstitium. Again, I want to make sure, because this is one of those things, especially when we get into fluid and electrolyte, and that's going to be a big, big chapter. Remember, it's the hardest test you're going to take in A&P3, or A&P sequence. When we talk about this, again, your desk, you can be thinking that they're all linked together, and that's the capillaries. That's where the blood is. Fluid, again, is going to leak out, but we're hopefully going to get it back. You are cells. The space in front of you, behind you, up above you, below you, is the interstitium. If fluid leaks into the interstitium and stays there, okay, it's referred to as edema. Edema is just a swelling due to fluid. And it's not a horrible thing for those of you who are on your feet all day long. If you go home, take off your socks, and you see a delineation where your sock was, it's not just because your sock was tight, it's because you have an increased amount of fluid there. Okay? Now, for those of you who work in the healthcare field, you might have taken care of grandma, and grandma has a bad heart, and she's got ankles that are this big. That's edema. And you can have it anywhere. Now, when edema is caused because the lymphatics is blocked or obstructed, it's referred to as lymphedema. So again, you can get that anywhere. All we're doing is we're identifying why you have the edema. So when it's caused by an obstructed lymphatic system, it's called lymphedema. Yes, sir.
Negative pressure when two veins come together, is that just for larger veins, or is that for...
It's only for the ducts.
Okay.
It's only for the right lymphatic duct and the thoracic duct.
Okay.
And I believe it's called the Bernoulli effect, but I'm pretty sure that's correct. Because you'll see it used in, the theory is used in a variety of other things, but it just basically means if I've got something that's coming in here, and I've got a high velocity that's coming through this way, right there is a negative pressure, which then pulls things in. So you'll see it with, I believe, fuel injections, I believe, use it to a certain degree, and jets have something to do with it, but we also use it in respiratory therapy. It's how we entrain certain things. So, any questions on that so far? Okay, so when I talk about the lymphatic system really is 3 things. Okay, it's the lymphatic vessels, the lymph and lymphatic tissue. Because I'm going to also have this tissue in different places in the body. Now think about the setup here. What did I say that the whole purpose of the lymphatics was? It's a fluid system, a treatment system. I'm going to collect fluid that's leaked out, I'm going to clean it and send it back. So that is a positive. Now, throughout this whole entire place, when we start talking about lymphatic tissue, okay, our lymph nodes would be lymphatic tissue. It's going to be cells. Remember what these were? What are lymphocytes? They're a type of white blood cell. And there are two types. Okay, we have B lymphocytes and T lymphocytes. Okay? And I'll talk about them here. I'm really not going to ding you, I don't think, until, I mean, it's all going to be in the same exam, but until we get the immune system is where we spend time specifically delineating the tasks of B lymphocytes and T lymphocytes. Okay? But they're our white blood cells. They're part of our immune system. Okay? So lymphatics, because they clean our blood, they're going to clean our blood of pathogens. So I'm going to need our immune system to do that. We have macrophages. What do macrophages do? What's the scientific term for what they do? Phagocytosis. Okay? The cellular debris. And then we have our reticular cells. Now reticular cells make reticular fibers, which is part of our lymphatic tissue. Reticular fibers made up what's referred to as a stroma. And a stroma is just a way of saying it makes a bed. Think of a hammock. That's what reticular fibers are. What's going to be on the hammock? Our cell. Just a B lymphocyte just kind of hanging there, waiting for a pathogen to go by. Ah, there's a pathogen, I'm going to activate the immune system. So, we have our reticular fibers, our hammock, and then we have the cells that are just kind of hanging out. Which should make sense, because what am I doing? I'm pulling stuff from the interstitium, and it's now going to enter into the lymphatics, so that I can alert the immune system when a pathogen, which is a bad guy, it's a disease-causing microbe, has entered. And then the body will hopefully ramp up the immune system to kill it so that you don't get sick. So the first part of this process, the first part where we see lymphatic tissue. Now, I'm going to talk about lymphatic tissue being spread out, but we also have structures of lymphatic tissue. Okay? Lymph nodes would be basically structures. Now, these processes go the whole entire route. So you can see them, and we're not even showing you all of them. I mean, you have thousands and thousands and thousands. But if you can anticipate blood coming up, so they've already encountered some lymph nodes down here. And again, this is where we're cleaning stuff. But it's going to go into here, and then when it goes into here, it's going to go into there. It can then go up to here. So again, it enters the lymph node, it enters a lymph node several times. Many, many, many times as it moves through. Cleaning and cleaning and cleaning. That make sense? This is what it looks like. Now, we're going to use some terms that I told you kind of come back over and over again. So you don't want to always just assume that it's with one system. You want to understand what they mean. And that's afferent and efferent. We heard about it first with our nervous system. We're going to talk about it here, and then we're also going to use the same terms in the renal system. Afferent means what?
Ascending.
Not descending.
Ascending.
Ascending. That's when we're using it specifically with the nervous system. But you're on the right track. Just think of it from a slightly different way.
Incoming.
Incoming. I'm bringing things in. So I have these afferent lymphatic vessels that are bringing things in. And then I have efferent that are taking things away. So again, that's why I want you to not get so locked into one body system. I want you to think about what the word actually means. Afferent brings things in, efferent takes things away. Now, the structure is we have a cortex, and then we have a medulla. Okay? So cortex, as you hopefully you remember from the very beginning of the term, means bark, like the bark of a tree, on the outside of something. Whenever you hear the term cortex, it will always be the outside structure, whereas the medulla is the inside structure. Okay? There's kind of an area in this spot over here. Now, do not get lost into the weeds on this. What I want you to know is that there is a cortex and there is a medulla. And as you move through, there are different types of cells. So our B lymphocytes basically hang out more in the cortex. And as you start moving through, we have B and T lymphocytes. And then as you get a little bit more in, you have more T lymphocytes. Not a big deal. Okay? Now, if I've got roughly, and we're going to use the picture on the screen, if I've got roughly 5 afferent fibers coming in, and I've only got 2 efferent going out, what do you suppose that does to the flow of lymph through here? Why is it important to slow it down?
There's time to clean.
More time to clean. Again, structure equals function. So not only am I going to send this through multiple lymph nodes as it makes its way up towards the duct and then back into the blood, I'm going to slow the process down so that there's a greater amount of time that the lymph is coming in contact with the immune cells that are present. So knowing that that's the process, okay, when we go back and look at this picture, so a benefit of the lymphatics from a disease process is I'm going to increase the amount of lymph nodes that it goes to so that I can allow my immune cells to come in greater contact with the pathogen. Can anybody see a negative to that process? What if I have tumor right here? Could the cancer cells not also then be spread throughout the whole entire body via our lymphatics? That's how they're spread. Cancer cells basically, when they start metastasizing, which is the whole point of evaluating nodes, and we'll talk about a thing called the sentinel node in a minute, this is the pathway. That's why they look at nodes when you have a biopsy. First, we want to see if the tumor, the mass, really is cancerous and not benign. But then I also want to look around there and see, did any cancer cells get into the surrounding area? Because if they did, then it means there's a greater chance that the cancer has spread to a different part of the body. So the positive lymphatics exposes pathogens to our immune cells so that we can attack it. The negative is it's a potential pathway for cancer to spread throughout the body. And other diseases, by the way, but cancer is a big one.
Are there ways to shunt, or does the body shunt the different pathways for the lymphatics?
No, it's just haphazard.
Okay.
Now, I will tell you, and I can't remember if it's actually on this slide or not, but I talked about a thing called the sentinel node. Yeah, I did. But since I've got it on the screen, I'll talk about it here. One of the things that they do, so if you were to have, I'm going to use a mastectomy as a example. So if you had breast cancer, in the old days, when they took a biopsy and they said, yeah, it's breast cancer, and then they would look, they would sample these nodes in this area here, okay? But to sample them, you basically ruin them. And what does the lymph system do? Drains fluid. So it would not be uncommon to see a woman who had breast cancer and had a mastectomy compression stocking on her arm, because that's facilitating the lymph going back up. Why? Because these are no longer able to do the job. So what they would do is you can inject chapter where you don't really want to study it at the start of it. Or a little, you open the page, it's like, woo! So here's the tumor. What they would do is they would inject a radioactive material into, not this picture, there's a picture I can show you, a radioactive material into the tumor. And then what they do is they then see what the first node is. So they take a detector and they're able to say, oh, this is the sentinel node. This is the first node that tumor drains into. And if there are no cancer cells there, they don't have to go to the rest of them. So you're not damaging all of the nodes in the area. So it's a much, much better way to evaluate than just simply sampling every single node. Any questions on that? Now, when you look at these nodes, one of the things that you're going to notice is there are areas where they tend to have a much, much larger concentration. They also tend to be very, very superficial at these areas, closer to the skin. Okay? So you might hear the term they aggregate. In other words, there's a bunch of them, they come together, or congregate. There's an increased concentration. This is one of the reasons why when you go to the doctor or your healthcare provider, they start walking their hands down your neck. They're essentially feeling for your lymph nodes to see if there's any of them that are enlarged. Okay? There is a movie, most of you are a little too young for it, but it's called Terms of Endearment. And there was a woman, she goes to the doctor, she's taking her kids there, the kid has to get a shot. So mom's going to take a shot to show the kid just, it's not really that bad. The doctor happens to grab her arm when he's giving the shot, and he starts palpating her axillary region and notices that there is an enlargement, and it turns out to be cancer. Rather downer of a movie. But here we have them in the cervical region, axillary region, and inguinal region. It's not the only place you have nodes, you just have an increase in concentration, and they tend to be very, very superficial, so they can be palpated by, again, your healthcare provider as they start to run their hands down. So when people talk about having a swollen gland, okay, or in your neck, they're generally referring to a lymphatic node that's swollen, okay? And they can hurt simply because in the neck region, they can limit a little bit of movement. When they swell, they kind of push down on surrounding tissue and so forth. So, any questions on nodes? Like I said, it's a fairly quick lecture. We do have lymph organs. Now, lymph organs, again, are specific to, yes, ma'am?
Are you going to go over the trabeculae and the sinuses?
No, that was the node, and I told you kind of what I wanted you to know from the lecture standpoint. I care more that you know there is a cortex, there is a medulla, and you do have afferents coming in, efferents going out. More afferents than efferents, again, slows the process down, makes it a little bit easier. I will tell you, and I think I forgot one part. So buboes, okay? A bubo is what is the term that was used for just a swollen lymph node. Okay? This is where the term, the bubonic plague comes from, called Black Death, because one of the symptoms of that particular disease was swollen lymph nodes. So, bubonic plague, buboes. Now, the lymphatic tissue and organs are kind of located in a variety of places. So we have lymphatic tissue, which is our tonsils. Our red marrow is lymphatic tissue that's present there. But we actually have glands. We actually have organs that are lymphatic organs. The thymus is a lymphatic organ. One of the things that we'll talk about in the immune system is this is where our lymphocytes know what to do. Okay? Very specific type of lymphocyte, but this is where they go to school. They're born over here, I send them over here, and they learn how to do their job. Okay? Just as a little preview, less than 2% graduate. So it's a fairly rigorous one. If you guys don't pass my class, you can take it again. If you don't pass the school here, you die. And only 2% graduate out of all of them that are sent. Just to give you a heads up. The spleen is another lymph organ. And then we have lymphatic tissues that are down here. I'm going to talk about each of those right now. So the spleen itself, and again, the spleen, when you go through it, it's going to really get into the anatomy of it. The important part of the spleen, when we look at it, is that we have what's referred to as white pulp and red pulp. And it's basically by design. The white pulp is essentially where we have the lymphatic tissue. The red pulp is where we start to destroy our red blood cells. Because remember, the spleen is the graveyard of red blood cells. Now, even though there's not a bone in here, you can fracture your spleen. It's just the term that the medical community uses. Often what we've done in the past is if your spleen is fractured, if it's lacerated to a certain degree via trauma, then generally they would do a splenectomy and they would remove it, so you can live without a spleen. Your liver kind of increases its activity to take over that function. Even your book says that if you don't have a spleen, you're at a higher risk for some diseases. You know, a little bit. It's, again, you can live fine without a spleen. What they found is, if it's not damaged too much, and it's not bleeding profusely, is you leave it alone, or you remove only part of it, and the rest of it will grow back. So knowing that, they don't do as many splenectomies for traumas as we used to a while back, because we realized that the structure can kind of heal itself, so to speak. Thymus, talked about. This is the structure of it. Again, it is an area for lymphocyte education, maturation. Those are the cells that learn what they're supposed to do. There's two areas to it, which is the reason why it's called bilobed. And it sits right here. It begins to atrophy after puberty because your immune system essentially is set. Okay, so it no longer has to do its job. If I was to do an autopsy on somebody who's 65, 70, 75, more than likely all I would find is connective tissue because it essentially atrophies. Okay? It's a great little tool from a diagnostic standpoint for infants and young pediatric patients, because if there's something happening in the chest, sometimes you get what's called a sail sign, where then, you know, this is generally where this kind of moves up, and it moves up because there's air there, so it's an indication that something's going on with your patient. It works out really nice from that standpoint. Tonsils. So when we look at this picture here, tonsils, if you notice, kind of have a circular shape to them. Okay? So essentially you have three types of tonsils. You have the ones that most people know, which are referred to as the palatine tonsils. Those are ones when you open your mouth, if you still have them, they're the things that basically hang down in the back of your throat that you can see. Okay? We have ones that are referred to as the pharyngeal tonsils. Pharyngeal tonsils, do you remember that tube that we talked about that equilibrated pressure between in the middle ear, so on both sides of the tympanic membrane? So that pharyngotympanic tube that comes down, very close to that is where you'd have another set of tonsils. Okay, these sometimes are referred to as adenoids. So those of you who either have had them removed or those of you who have kids, we don't do this as much as we used to, but it was called a TNA, tonsillectomy and adenoidectomy. really what you're doing is it's tonsillectomy. It's just when pharyngeal tonsils become inflamed, that's when they're called adenoids. But some people just refer to them as adenoids all the time. So that's where the TNA comes from. And then we have lingual tonsils. And lingual tonsils were on the posterior 1/3 of the tongue, even a little bit farther back. So if you think about your tongue, so it's a structure, it's going to come back here, and then you have, it's not this big of a space, but you've got your trachea here, and you've got your esophagus there. Let's make this a little better. And you have a structure that essentially will cover the trachea when you take fluid in, so it doesn't go down the wrong pipe. And then your lingual tonsils are back. And these all have lymphatic tissue. Now that kind of makes a little bit of sense where they're located, because this is where stuff goes into your pie hole. So things that you smell, things that you eat, they're all coming back here, and you have the potential of introducing pathogens, like a steak that sat out on the counter too long, and you're like, it smells okay, which by the way, the smell test really doesn't work. There's a lot more bacteria that are going to hit there before it ever changes the smell. And there's a happy medium between, someone like myself who's fairly germ-phobic. So if I grilled chicken breasts last night, if I don't eat them by lunch today, then the chicken just goes away. And I have siblings that are like, it's good for 5 days. So, but you're putting things in it. You're introducing it to your body. So when I've got this circular area right here, it increases the chance of introducing any potential pathogens to my immune system, therefore activating it. Okay? Now besides the tonsils, we have what's referred to as a mucosal associated lymphatic tissue. And the L is sometimes there, sometimes not. It's a potato thing. Sorry. It's not going to look the best for what I want to do, but mucosa-associated lymphatic tissue, MALT. And again, remember I told you that the tissue, so our lymphatic system is the lymphatic tissue, and the immune cells that are present. I kind of lost my brain. Now I can take all those things and put them in an organ, or I can leave them as tissue itself and spread them throughout the body. And that's what I was referring to. So we have organs and we have other things. These things are associated with the mucosa. Okay, sometimes we have them, it used to be called MALT, because this was gut-associated lymphatic tissue, but we realized that we had the same type of immune response in the mucosa of our respiratory system. So they just changed it to the mucosa-associated lymphatic tissue. And you can see it back on this particular diagram in here. Now, in our GI tract, our gastrointestinal tract, we do kind of name it specifically, and they're referred to as Peyer's patches, okay, named after the anatomist that discovered them. But Peyer's patches would be an example of the mucosa-associated lymphatic tissue. Now, the very last part of the lecture, well, the appendix, by the way, the appendix is a little finger-like structure that hangs down on the beginning of your large intestine. Comes off of what's referred to as the cecum. Okay? So on your diagram, it's right here. And it sits in such a position that specifically with adolescents, it tends to have a better angle, so that by this point, since we haven't talked about the digestive system, you're starting to talk about fecal mass here. So I told you about naming things. So when you eat things, we change it to a bolus. Once it goes to a bolus, it goes to our stomach. We call it chyme. From chyme, it goes all the way down here. We absorb things, and then it's going to turn into feces. So that's that process. It's about starting right here. So the small intestine is going to let it drain there, and it comes down. And in younger people, this is more of a direct connection, so it has a tendency to fill and get blocked. Okay? When these get blocked, that's what's called an appendicitis. Now the problem is that this can be this basically inflamed bag of pathogens and all sorts of toxins, and if it ruptures, then it can spread all that to the whole entire peritoneum, and you can have a systemic disease. Okay? So, and again, this is very similar to the spleen. The spleen has extra tasks besides the immune system. That's all that is. So if you don't have an appendix, no harm in that. So the only other thing besides, when we talk about the sentinel node, kind of the big disease processes that are here, is a type of cancer. And the naming of it is such, so it's called Hodgkin's disease. Hodgkin's disease is where you have an enlarged gland, but it's not painful. Okay? And the diagnosis of Hodgkin's disease is a type of cell called a Reed-Sternberg cell. They look like they've got big giant owl nuclei that are present. They're big structures inside the cell. Has a fairly good cure rate, depending on when it's diagnosed. Now the problem is, there are a bunch of other cancers that fit into this category, but they're not Hodgkin's. So they're called non-Hodgkin's lymphoma. So usually, some people will just say I have Hodgkin's disease. Really, that's Hodgkin's lymphoma. It's a type of cancer of the lymphatics. But it's a type of cancer of the lymphatics that, again, has a very specific type of cell. Whereas, if it doesn't have those cells, but it's still a lymphatic cancer, cancer of the lymph, then it's called non-Hodgkin's. And again, there are multiple types of non-Hodgkin's. So there isn't just non-Hodgkin's lymphoma. There is a delineation. Kind of like when we talked about acute lymphocytic leukemia, chronic lymphocytic leukemia, there's a whole bunch of stuff that goes into it. We just kind of glaze over it so that you kind of are a little familiar with the term, so to speak.
And the cancer, like the cell, is called Reed-Sternberg cell?
No, Reed-Sternberg cells have to be present to have the diagnosis of Hodgkin's lymphoma. And again, they're very specific. They've got these two big, giant, round structures that look like owl eyes that are in it. Any questions? So that's lymphatics. Pretty straightforward, mostly anatomy. I would make sure, today, I would basically try and have your lymphatics down at some point today. Understand the structure of the lymphatic system, understand the naming of it as you move through. Those can all go on flashcards. This is just pure rote memorization. Because when we start to get into the immune system, there's going to be a lot more material. It's a lot harder. And the reason why it's a lot harder is simply because if you think about going to a play has several acts. And in the acts, you have different characters. And what people try and do is they try and put together what happened in Act 1 with what's happening in Act 3 and make the characters, and sometimes that's hard to do. So that's the reason the immune system is a little bit more complicated. So I try and get this down as quick as possible. So we will start the immune system tomorrow. Okay?